to their presentation, also to their careers. So this year we are again back with the new season of Rising Star. And to tell more about it, we have with us Dr. Sanjay Dar, past president of BOS. Over to you, sir. So you're muted. Just unmute yourself. Yes, sir.
Hi, good evening and welcome everyone. This is one more edition of this Rising Star of Bombay Orthopaedic Society in our endeavor to allow youngsters to provide them the platform and get them going in the academic world of orthopedics. This is what we had started last year, and I'm sure we'll continue this year with the galaxy of youngsters enrolled for this session. So today being the arthroplasty session, I welcome all the participants in this orthoplasty session. I welcome the judges and our secretary, Dr. Ashish Padnis. And I think we can start. Welcome and all the best.
Thank you, sir. So let's not waste any time and invite our first participant, Dr. Abhishek Nighot. He'll be presenting on impact of kinematic alignment in total knee arthroplasty. So over to you, Abhishek. You can start sharing your presentation.
Sure, sir. Good evening, everybody. It's a pleasure to kick off the BOS Rising Star for 2024. My topic for today is impact of kinematic alignment in total knee arthroplasty. It's a narrative literature review. My methodology would be PubMed and Google Scholar articles with systemic reviews, meta-analysis, and randomized control trials. Before we start off, let us understand what is kinematic alignment. The school of thought was first by Hungerford, but it was popularized later with Caliper Verifies Kinematic Alignment by Dr. Stephen Howell. Dr. Stephen Howell explains this as it restores the patient's pre-arthritic joint line using 3 kinematic axes without releasing any of the healthy ligaments and restoring the resting lengths of the ligaments. Now let us look at what are the 3 kinematic axes. The first one is the axis with which the tibia flexes and extends over the femur. The second one is the axis with which the patella flexes and extends. And the third one is the medial ball and socket with which the tibia pivots over the femur. Now, why this debate? That's because mechanical alignment has come with its own set of problems, with up to 20% of the patient annually who have a non-satisfactory outcome. This is proven time and again with multiple researches, the latest one by Dr. Robert Brown in the year 2017. This is quoted directly from Insol's paper in the year 2000 that even with meticulous attention, perfect soft tissue balance is not always achieved in total knee arthroplasty. And patellofemoral mechanism related problems such as overstuffing the lateral extensor mechanism, which was proven by C. Revere in his 2007 article, which describes about some intrinsic technical limitations in the mechanical alignment. The most recent article was 10 flaws in systemic mechanical alignment was by Dr. Becker, in which he describes that there are certain assumptions that are with the mechanical alignment. Namely, they assume a neutral alignment for all, which is not true. They oversimplify a complex 3D anatomy geometry. We assume that the disease compartment is always tighter and therefore always requires a release. And mediolateral and flexion extension gap balancing should be isometrical. But are we all aligned in neutral? A recent paper by Bellmans in the year 2012 said that an important fraction of the normal population has natural alignment of 3-degree varus or more. This means 32% of the population is in the varus axis of the HKA. So how is kinematic alignment different from a mechanical alignment? In a mechanical alignment, we cut the tibia and femur 0 degrees to the mechanical axis in extension. We rotate the femoral component parallel to the transepiphyseal axis, and we balance the soft tissues in flexion and extension to have a perfectly rectangular gap balance. So essentially, the mechanical alignment is, in the mechanical alignment, the tibial cut is what drives the surgery. Whereas in a kinematic alignment, the femoral cut will drive the surgery. The distal femoral cut is kept parallel to the joint line after considering articular wear, which is about 2 mm, proven by multiple studies. The tibial cut is then parallel to the femur cut, and there is no or minimum soft tissue balancing. A rectangular tight extension space is what we want, but in flexion, what we look out is for a trapezoidal flexion space. This is because it is proven by Roth and Howell that the native knee laxities are different at 0 degrees and at 90 degrees of flexion. So if we have a perfect rectangular gap, that means we are overly tightening the soft tissue restraints relative that of the native knee, which patients may perceive as pain, stiffness, or limited flexion. Now let us look at some evidence of mechanical versus kinematic alignment. This is a landmark paper by Dorset et al. In the year 2014, in which he conducted a randomized control trial of 88 patients in the Bone and Joint Journal with a 2-year follow-up. He found that there is a significant discrepancy in the Oxford knee score, with kinematic alignment having a much better Oxford knee score compared to the mechanical alignment. However, this difference could not be reproduced in the later studies. We also look at the joint line orientation and mechanical axis position, which was studied by Matsumoto in the year 2017 in a 60-patient randomized control trial. He found that the joint line orientation is in fact better in the kinematically aligned knees as compared to the mechanical aligned knees. He also found that the knee flexion was slightly better in the kinematically aligned knees. The knee society score, however, was equivalent. Let us look at another study in the year 2017 published by Callis et al., which was a 200 patients RCT, which said that the knee society score was significantly better in the kinematically aligned knees as compared to the mechanically aligned knees at 12 months of age. But when we look at a kinematic alignment, we always think of tibia in varus. Well, kinematic alignment is not about putting tibia in varus. It is actually the femoral morphology that decides the tibial osteotomy. Equal resection is what is done in the distal femoral cut, in accounting for the cartilage wear as well, and equal posterior resection accounting for the cartilage wear. But tibia and varus is often associated with aseptic loosening. Is that true? Lende et al. In 2019 proved with RCT comparing mechanical and kinematic analysis with the radio stereophotometric analysis, in which the moment of total position momentum was the same in the year 1 and 2 for both mechanical and kinematic analytic patients. This is again a landmark study by Howell et al. In the year 2018, who is in fact the person who started kinematic alignment. He studied a 10-year observational study of his own knees, which was 97% of survivorship with a staggering Oxford score of 43 and a WOMAC score of 7. If you look at this graph carefully, you will find that unlike popular belief, 73% of the patients have a hip knee angle axis at 2 degrees varus to 2 degrees valgus. There is not much of an outlier as what is believed. Another paper, which was again published by Howell et al. Recently in the year 2023, has 220 knees, 60-year follow-up, shows that the implant survival is 93%, out of which tibial components of 35% of those are up to 8% varus, which means that tibial varus is perfectly compatible with patient implant survival. The Oxford knee score here was also 43 and forgotten joint score was 88, which is also significant. Now we've looked at the subjective parameters. Let us look at some objective parameters as well. Now, it was proven by Nikki et al. In the year 2017 that kinematic alignment reduces knee adduction movement more than mechanical alignment. And the peak knee adduction movement, which was studied, was significantly lesser in a kinematically aligned knee, which means that the force required for a person to walk would be significantly lesser in a kinematically aligned knee. Also, this is a very famous paper called CPAC classification. We know of the classification and we know there are 9 types of phenotypically aligned knees. But this paper also studied the intraoperative compartmental balance at 10 degrees of flexion and found out that kinematically aligned knees have a better outcome in all the phenotypes as compared to the mechanical aligned knee. Lastly, let us look at a meta-analysis by Von Essen et al., which was published in the year 2023, which shows that the Oxford knee score, the forgotten joint score, are significantly better in the kinematic alignment. However, the WOMAC and the Knee Society score are equivalent. So the summary is that knee arthroplasty comes with some unsolved problems, alignment being one of them. But kinematic alignment is an established alignment philosophy and is certainly backed by evidence, as we can see. It is safe with over 16 years of implant survival data. Although the survival data is by one person who is propagating kinematic alignment, more further studies are needed to prove long-term results. The clinical outcomes are similar to that of mechanically aligned knees as we look at the forgotten joint score and the Oxford knee score, and the knee is balanced with the mean adduction force required being less. Thank you. These are my references.
Thank you, Abhishek. I'll invite Dr. Girish Devnani and Dr. Avinash for questions. Go ahead, sir. Girish, sir, you can start or unmute yourselves and you can ask.
Did he finish in time?
Yeah.
Am I audible?
Can you hear me?
Yeah.
Yes.
Yeah. Okay, Girish, after you.
Okay, Abhishek, well researched and well presented, and a very extensive literature review. Now, tell me one thing. Do you feel that the kinematically aligned patients are happier, or only is the scores in the initial period that are saying good? Because all the studies you presented, the most of the WOMAC and the Knee Society scores were pretty similar.
That's right,
And
sir.
do you feel that if most of us who are listening to you today and who have already been doing knee replacement in the last 15 years have all adhered to the philosophy of mechanically aligned knees, wherein now we always strictly, stringently try to avoid a varus tibia because of the early rates of failure? Are we fair to say that now, even if your tibia is into 3 or 5 degrees of varus, it will not fail? Do we have long-term results supporting it? Because mechanical aligned knees have got a proper result saying that the tibia is in more than 5 degrees varus, it's not going to probably last. What is your feeling, and how does this data change between a Western population and an Indian population? All the data that you presented from the Western population, which have got essentially stiff joints, while our joints here are more lax. Would that make a difference, in your opinion, about how they behave?
So to answer your first question, we certainly need longer studies. With what we have seen previously, the 2-year, 3-year follow-ups have been equivalent. So we certainly need to see longer studies as far as the stability of the alignment is concerned. And as far as your second question goes, sir, certainly with Indian populations, we have more of the deformities rather than stiffness, and patients often present with severe deformities. However, sir, kinematic alignment does not rely as much on the bone loss of the tibia. It understands is the bone that in the femur there is almost always no bone loss, even in a severe deformity. So what they account for is only the cartilage loss, and so severe deformities can also be tackled well with kinematic alignment. However, what you said is extremely right that long-term studies are definitely the need of the hour as far as kinematic alignment is concerned, but it is evolving as we speak.
Okay. Got your
Abhishek,
point.
can I ask you something? You mentioned about John Insull's verdict, but I don't know if you're aware, the last verdict by John Insull was there is no substitute for mechanical alignment. The reason being all these controversies coming up, his presidential address. So now I had one question for you. You mentioned that you take the femur as a reference for your cutting of the this thing on your cutting jigs. So in severe varus knees or severe valgus knees, sometimes you have eccentric wear of the femoral condyle. So what is your referencing? How do you decide on the femoral cut in a
Sir,
kinematic alignment? Because there is a wear of the condyle posteriorly as well as there is a posteromedial deficiency also.
Right, sir. So it is often seen that there is a febrile condyle hypoplasia, as like we call it in some conditions. But there is a paper in 2014 that Naim et al. Has have written, in which they say that the femoral wear can be very correctly predicted with the help of and that there is almost always no bone loss even in severely deformed knees. So what we rely on essentially in kinematic alignment is the fact that we assume that there is no bone loss and there is only cartilage loss even in severe varus or valgus deformities.
Because the danger is of internally rotating the femoral component. If
That's right.
your cuts are inaccurate, which
Yes.
problem never happens in a mechanical alignment if you have a good orientation. So this is just a point of debate. I was just checking.
Yes, sir.
You had excellent presentation.
Thank you, sir.
Abhishek, one last question.
Certainly,
All your current robotic systems are tuned towards kinematic alignment. Am I right?
Sir, actually, I'm not really aware of
Yeah, but
robotics.
just for your information,
Right.
all the robotic systems are focusing towards putting the knee mechanically well aligned. But this CPAK thing also seems to be something which is coming up. So have you had a chance to read a little more about the CPAK system? Or
Yes,
it's
sir.
something which not, yeah.
Sir, McTessie et al. Has described this system. It is basically classifying the alignment of the lower limbs into 9 different phenotypes, out of which type 2 is the most common, which is the neutral one. But having said that, there are certain aspects of the population wherein these other phenotypes are also common. And after describing this classification, McDesai has gone on to say that kinematic alignment has balanced the knee well in all these phenotypes as compared to mechanical alignment in his paper in 2014.
Abhishek, one last question.
Yes, sir.
If you were to do your mother's knee replacement, what alignment would you use?
Sir, I have seen and trained only mechanical, sir. I would still do mechanical.
That answers my question. Oh, sorry. Thank you.
The answer should be I will do a robotic knee replacement, Abhishek, today. You make Ashish Fadnis very happy. Learn to see who your judges are. You must always go towards them.
Yeah.
Well done. Good one.
Well
Thank you,
done.
sir.
So
Thank
any
you.
other question, Ashish? You have any questions? Or Darza?
Abhishek, good presentation. Are very well presented, well within time, very clear. And no, I mean, questions wise is okay. I would just like to make a comment is that, yes, CPAC classification, you mentioned that type 2 is the second one. Now that you're talking about your literature review and your presentations, we actually have Indian data. There's a paper from 2 or 3 different centers. One of them I know for sure is Professor Gurwa Reddy's center, where they have looked at Indian phenotypes and where they are. So apex pointing neutral, apex pointing proximal and distal. So I think Indians are 1 and 4 is sort of more common in the Asian population subset that is there. So therefore, as Dr. Devrani said, we need to an Indian data also that what is our phenotype and what are we giving them post-op. So are we changing the phenotype post-operatively and are those people very happy? And
Right.
so one more, I mean, to take this point further, as Dr. Devrani correctly mentioned, that most of these studies are not showing a significant difference. So I'll just push you a little further and ask, do you feel our scoring systems have something like a ceiling effect?
Yes, sir. Certainly, Oxford knee score certainly has a ceiling effect, and it's been well proven that it has a ceiling effect. The forgotten joint score, however, is more reliable as far as this data is concerned.
Look, करता है क्या?
Ashish, one more thing. Ashish, further to what you said regarding the Indian data, even Professor Gurwa Reddy has declared that the PROMs, the patient-related outcome measure scores, where you mentioned 20%, Abhishek, that
Yes,
is
sir.
10% according to his studies, which are huge numbers. So in Indian population, probably the incidence of unhappy knees is slightly lesser.
Yes.
It depends on how much they pay for the knee.
Yeah, true.
Sorry.
True.
Okay, I think that ends our first presentation. Thank you, Abhishek.
Thank you,
It was
sir.
a great presentation. And next, I'd like to invite Dr. Chandan for his presentation. Go ahead and share your screen.
Is my screen visible?
Yes.
Should I start?
Yes, go ahead. Start.
Good evening, everyone. I am Dr. Chandan Mehta, Senior Resident in Department of Orthopedics at CHGS Medical College and KM Hospital. Today, I'll be talking about dual mobility cups in hip arthroplasty, their use and effectiveness in preventing dislocation. Total hip arthroplasty has been termed as the operation of the century. And like any other surgical procedure, it comes with its own complications. A major cause of the failure of the total hip arthroplasty is the instability leading to dislocation. The incidence of the dislocation varies from 0.2% to 7% after primary total hip arthroplasty and 10 to 25% after revision hip surgeries. Why instability is important in total hip arthroplasty?
We can't hear you properly.
Instability is the second most common cause of revision in 15% of, and it is in. Sir, now audible? Hello.
Not
Clear.
clear.
Hello.
Ashok, not clear.
Voice is not clear. Yeah.
Dr. Chandra, can you speak up?
Sir, now I am audible.
Yeah, you're audible. Go ahead.
And instability instability is the second most common cause of re-revision total hip arthroplasty in revision hip arthroplasties. It accounts for 25% of revisions after a revision hip surgery. Is dual mobility cup a key in unlocking the stability of the hip arthroplasty? We will look at the literature. Electronic databases such as PubMed and Google Scholar were searched with keywords dual mobility, hip arthroplasty, dislocation with a filter of 20 years to include the studies. Systemic reviews, meta-analysis, and National Joint Registry data were included. Studies with high citation index were chosen. A look at the history of the dual mobility cups. The idea of the dual mobility cup was the brainchild of Professor Gilles Bosquet and his engineer André Rambert. They combined the principles of Chanley's low friction arthroplasty and McKay-Farah hip, which utilized a larger head size, and this led to the birth of dual mobility cups. The first dual mobility cup design was a cemented tripod cup with a polyethylene liner locked onto the ball head. Promising results were seen. The dislocation rate was only 2.2% at 3 years, which was compared to 5% with the Chanley processes at that time. How does a dual mobility cup work? A dual mobility cup has two articulations. One articulation occurs between the femoral head and the polyethylene liner, and the second articulation occurs between the polyethylene liner and the outer metal shell at extremes of range of motion. How does a dual mobility cup prevent dislocation? Increased cumulative head size and an improved effective head-neck ratio leads to increased jump distance and impingement occurring only at higher extremes of range of motion, leading to lesser chances of dislocation. Types of modern design dual mobility cups. The modern design dual mobility cups were approved for use by US FDA in 2009. There are two types, anatomical dual mobility cup and the modular dual mobility cups. The anatomical dual mobility cup has an anatomic design. It has a recess anteriorly for the iliopsoas tendon, and there is no provision for screws. So one has to achieve a press fit in the acetabulum by performing the surgery. Whereas on the contrary, modular dual mobility cups have a titanium acetabular shell which has provision for screws. Over the shell goes the highly polished cobalt chromium liner, and the polyethylene liner articulates with this shell. But this shell has a disadvantage, but this modular design has a disadvantage that it reduces the size of the polyethylene liner that can be used and thereby decreases the jump distance. So anatomical dual mobility cups have a larger jump distance. Current trends in the use of dual mobility cups. This is the data from American Joint Replacement Registry, and from 2012 to 2020, there was a steady increase in the use of dual mobility cups in primary total hip arthroplasty as well as revision surgeries. But recently, from 2020 to 2024, there has been seen a decrease in the use of dual mobility cups. The data is from American Joint Replacement Registry, and we will see later in the presentation that why this is so. Dislocation rates following the use of dual mobility cups in primary total hip arthroplasty is around 1.1%. Thus, intraprosthetic dislocation rates are also 1.1% as per study by Andrew Gardner. And dislocation rates in revision total hip arthroplasties is 3% with dual mobility group, whereas it is 10% with the 40 mm large femoral head group. Complications which are specific to the dual mobility hip arthroplasty. The first is intraprosthetic dislocation. It is the dissociation between the femoral head and the polyethylene liner. The incidence is only around 0.7% in primary hip arthroplasty and 1.3% in revision hip arthroplasty. It always needs surgical management. The incidence of intraprosthetic dislocation has decreased recently because of the improved polyethylene liner, as well as because of improved head size, which now utilizes 28 mm head. The intraprosthetic dislocation can be missed on an X-ray, whereas on CT it can be seen as a shadow of the liner. Another point which was concerning regarding the double mobility cup was the accelerated wear of the polyethylene because of the double articulation. This was a problem only with the previous generation designs. With the newer highly cross-linked ultramolecular high weight polyethylene liners and the vitamin E poly, the wear rates are now comparable to the standard total hip arthroplasty implants, and this has been approved both by in vitro studies and the in vivo studies. The wear rates are comparable to those of standard implants. Serum metal ion levels. This is the cause of concern regarding the major concern, which has led to a decrease in the usage of dual mobility cups in the United States. Because of the multiple articulating parts, there is fretting corrosion between the femoral head and the stem, and another fretting corrosion has been observed between the liner, the chromium cobalt liner, and the titanium vestibular shell. A study by Madsen Co. has shown serum cobalt levels to be more above the normal range in 21% of the patients, and 9 patients had more than 1.6 micrograms per liter. Mars MRI done in patients with serum cobalt levels more than 4.5 microgram demonstrated acute leukocyte tissue reaction in 2 patients. A systemic review and meta-analysis by Iactas showed 6.9% patients having elevated cobalt, chromium, or both levels above the reference range. The serum ions were elevated only within the first few months post-operatively and decreased with the long-term follow-up. So it is not possible because of the fretting corrosion. Because fretting corrosion, if would have been the reason, it would have led to increased levels post-operatively after 1 or 2 years. Cobalt levels were elevated in 3% of the patients with ceramic heads and in 8% of the patients with metal heads. But this was not statistically significant. Current indications for dual mobility total hip arthroplasty are reserved only for the cases which have a higher risk of dislocations, such as revision hip arthroplasty, primary total hip arthroplasty in old patients with femoral neck fractures, patients with stiff spine or hip, cognitive dysfunctions, and neuromuscular disease. In summary, dual mobility curves are effective in reducing the dislocation rates in both primary and revision total hip arthroplasties. They have survivorship comparable to that of standard implants. Growing concern regarding the increase in the serum metal ion levels. Metal reactions such as alveolar ALTR and pseudo tumor, which were earlier seen with the metal hips, needs to be studied over longer term, especially in the modular dual mobility designs. These are my references. Thank you for Bombay Orthopaedic Society for this opportunity.
Thank you, Dr. Chandan. I'll invite judges for the questions. Over to you, Girishan.
Yeah, Chandan, thank you for your nice presentation. So tell me one thing. In an 80-year-old lady with an intracap neck femur, who is reasonably well affording, would you offer her a bipolar or would you offer her a dual mobility? With your reading, what have you gauged?
Sir, if I would look at the activity levels of the patient in the 80-year-old, if she was performing all her routine activities pre-fracture, so I would like to go with the total hip arthroplasty. And if she is performing just her routine daily living activities, then a bipolar, probably a cemented bipolar because of the poor bone, likely.
No, we are not getting into cemented or uncemented stems. The dual mobility is irrelevant of that. Okay. I am asking you a simple thing. Would you today prefer a bipolar over a dual mobility, provided the patient has got an equal financial thing and the patient is reasonably mobile without, it's not bed bound?
So I will.
So do you have any literature saying whether the dual mobility is better than the bipolar in neck femur fractures in an 80-year-old patient? Any literature support this view or not?
Correct. Sir, I have not looked for the literature on this point, but if
Okay,
I would.
okay, fine. Okay, fine. So, second question: 35-year-old AV and hip post-COVID, very common scenario. I'm sure you've seen a lot in the
Yes, sir.
KEM hospital and everywhere else.
Yes, sir.
Would you offer them, if they are people who are high demand in terms of activities, like say a farmer who requires ground level activities, etc.? Would you
Yes, sir.
offer them a dual mobility on day one, or would you prefer to go the conventional total hip?
Sir,
And
in
if so, why?
a younger patient, such as 35-year-old, as you mentioned, I would like to go for a conventional total hip replacement with a larger femoral head, around 32 or 36 size. It also, now with larger heads, the dislocation rates are less. So I would like to go with the standard hip.
Now, what is your objection to dual mobility, my friend?
Sir, dual mobility, I would like to.
You just ended your summary slide saying equal survival rates as conventional implants.
Yes, sir. 80% it is around 77% at 20 years in a study, sir.
Yes. So why not dual mobility on day one? There are some mavericks in Bombay doing it.
Sir, it can be done, sir, but because there is no long-term data to support the.
I will tell you what the answer is. The answer is that the conventional total hip replacement that you do today has got ultra high molecular weight polyethylene liner available. While most of the dual mobility articulations available today in the market, at least in the Indian market, do not have that as yet. So when a similar level of poly comes in, plus or minus vitamin E, then that could be considered. But till then, we will restrict it to the 70 plus age group. Okay, that's my take. Avinash, your opinion.
Good presentation. Actually, Chandan, you have overlooked one slide. In one of your slides, you have clearly mentioned when you would do a dual mobility. That is the elderly patient, cognitive dysfunction, and all that. So I think that could have been probably your answer for the Girish's question. But anyway.
No, Avinash, in that slide, he's written the first one is written neck of femur fractures. That's why I asked him.
So obviously, the only one thing I want to check with you, you have shown certain papers where you have shown that the survivorships are very high, but they are only up to 10 years. Have you procured any long-term data for the survivorship of dual mobility implants in younger patients?
Sir, there is a paper in which there is a 15-year follow-up and a paper which mentions about 77% survival at 20 years. So there is one paper which I could, but most of the papers are up to 10 years. There is only one paper which mentions.
Yeah, exactly. So that is what is worrying us, and that is a message we want to give all our juniors, that don't start doing dual mobility for everybody. What Girish was exactly highlighting, that there will be certain selected group of patients where you'd want to do. So, reframing it the other way, if you have an 80-year-old who's physiologically very active with a good muscle bulk and no cognitive dysfunction, I wouldn't hesitate to do a bipolar. So that would be the possible listing. But it depends upon your, apprehension level, how much you will think that the hip can get dislocated at that point.
Yes.
Avinash, why not dual mobility?
No, if the patient is extremely reliable physiologically.
No, reliable. Okay, very reliable.
Sometimes you get a patient who's like, instead of 80, he looks 70. So there, why you want to take it's your comfort level. Bipolar is not totally excluded. What I mean to say, Girish.
No. So I'm playing the devil's advocate here. I'm playing the devil's advocate. I want to know if you are comfortable putting in a cup.
Absolutely.
Okay.
Absolutely.
Then why should I not do a dual mobility for every patient who is 75 plus? And because the question is here, today she is good. Okay, he or she is good with you. After 2 years or 3 years, she gets some theory of dementia and is not cognitively good. Nantar kya karna?
So those things happen once in a while, I agree. But only thing is then you have to accept the morbidity of going ahead with a total hip and that. It's a little debatable thing.
The morbidity what? I mean, like, come on.
So Girish, we have a lot of long-term data on bipolar hip arthroplasty with excellent results, especially the exeter stem, etc. at the end of 10 years, 15 years.
I mean, a stem is same, exeter only, but dual mobility.
Yeah. So what I'm saying, with a bipolar also, there is a good long-term data available, provided you have chosen your patient correctly.
Right. I think even experts can differ. That is what.
Yeah.
Yes.
Evident here. So
very well done, Chandan. Very well presented.
Yeah. Thank you, sir.
We have Dr. Mohan Desai with us, President of Bombay Orthopaedic Society. Hello, sir.
He can ask question on dual mobility.
Yes, sir. Go ahead, sir.
Hi, sir.
Sir,
I
unmute
wanted a
yourself.
question before Mohan Desai. I welcome Dr. Mohan Desai. Has Dr. Chandan, have you got any latest what Dr. Giri said with the present materials? We are in generation 3 now of dual mobility. The literature is all generation 1. So have you been able to get hold of some latest literature on it? That was the whole point. We are not discussing dual mobility 20 years old and comparing with each. So with different polys, with different this, have you found any literature or tried to look for it?
So the recent literature,
Because the whole ball game may change now, and these materials are available in India now.
Sir, there is decreased wear rates with the newer implants, with the development of the new poly, vitamin E poly, and the crosslink, highly crosslink poly. The wear rates have decreased, and further with the use of ceramic head or the oxinium head, there is further decrease in the wear rates. So
So could you get any literature? Did you try to look for any latest literature?
Sir,
Not available, sir.
So there is, I look for the literature, but it mentions only up to the follow-up was 10 years. So probably the patients which were operated, they were operated before 2016 and 2017. The long-term data.
Okay.
The patients were operated before 2017 in the long-term data. There is a recent paper by Dr. Sanjay Londe. He has a 5-year follow-up, and he has reported excellent outcomes of the patients. But this is only by only 5-year follow-up, and probably later at a later date we can get more accurate data.
Okay.
Yeah, Desai, sir, you can ask question.
As I said, the work is done. My conflict of interest, I leave it to the judges. Is from KM, so I won't ask, but good. I saw apologies for joining late. I had some technical glitch, so I couldn't join early.
No problem.
Please, yes, thank you.
Okay, welcome again, sir. And let's move on to our next presenter, Dr. Soham. Go ahead and share your presentation, Dr. Soham. So Soham will be presenting on
Yes, sir.
role of vitamin E induced liners in TKRs. Are you able to share your presentation, Soham?
Yes, sir. Just a minute. I'm
Yeah. Now you're sharing your desktop. Share the presentation. Go back.
So is it visible now?
No, you're sharing your desktop. You have to share the presentation. Open the share screen, find your PowerPoint, which is open.
Yes.
Keep your PowerPoint open.
Okay.
Yeah, now we can see it. You can go to slideshow.
Is it visible, sir? No?
Yes, go ahead.
Okay. 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 A very good evening to all. I'm Dr. Soham Ranade. At the outset, I would like to thank Bombay Orthopaedic Society for giving me the opportunity to present on this platform. The topic I will be presenting on is the role of vitamin E liners in total knee arthroplasty, a review of wear resistance and longevity. So let's go straight ahead. Now, why should we know about it? Polyethylene is the most perishable object in a total knee arthroplasty. It is being happening in our data that there are more young patients, more hefty patients, and more active patients which are now taking part in total knee arthroplasty. All this causes increase in debris, increase in osteolysis, and increase in implant loosening. And therefore, the gravity of this situation is that there are almost 50% of all the revisions which happen because of polyethylene wear and implant loosening. Let me take you to a time long ago when Sir John Chanley first introduced the ultra high molecular weight polyethylene. He named it as RCH1000 by the name Ruhr Chemie, where it was discovered. With due course of time, several modifications have been added to this, and now we know an overview of this process in which it is a monomer resin, so to say. A monomer resin. Just a minute, I have lost the presentation, sir.
No, we can see it. Go ahead.
Yes, just a minute.
Okay.
On something.
You can stop sharing and share again. Yeah, I'll stop your presentation. Yeah, you can go ahead and share again. Okay, we can see your presentation. Make it slideshow and go to the slide you were stuck on.
Yes, sir. Slideshow.
Okay, we can see it. Go ahead.
Okay. Yes, sir. So now we know an overview of the process in which it is a monomer resin, so to say. After it is gamma irradiated, it forms a highly cross-linked polyethylene, and then it is melted and annealed. But these processes also have certain drawbacks. At the process of gamma irradiation, there are many free radicals which are formed. Now, after reviewing the data, going through multiple papers and registry, my objectives are I wanted to find out the review of the literature and find out the wear rates in vitro, the animal models, and in vivo comparison of vitamin E liners and compare with them in conventional liners, the longevity of vitamin E polyethylene and its comparison to conventional, the quantity of vitamin E actually does it influence the wear rates of polyethylene? If so, how? Does the method of vitamin E inclusion affect the outcomes, blending versus doping? The impact on mechanical properties with and without polyethylene, and does it have any antimicrobial and anti-inflammatory properties per se? I have gone across electronic databases, PubMed, Google Scholar. All studies included are within a gap of 15 years from now. The studies with high citation index were chosen, and the national data registry from different countries were taken. I could find as much as data as I tried to find out from UK, Germany, Finland, Belgium, Australia, Sweden. Now, coming to the free radicals, the impact on polyethylene was threefold. It had a neutral impact in which it bound to the hydrogen atom. There was no change in the structure. There was a positive impact when it cross-linked with other free radicals, increased the wear resistance but made it brittle, and a negative impact when it bound to oxygen atoms, caused cleavage of the molecular chain by oxidative degradation. Now, this alpha tocopherol, what does it do exactly? These free radicals, when they combine with oxygen, they form reactive oxygen species. Now, these reactive oxygen species, when they link with alpha tocopherol, this vitamin E gives one electron, and thus the quench of the thirst of free radicals is met, the electron donation is done, and they are stable. Vitamin E can be added in the polyethylene by two ways. One is by blending, in which the vitamin E is added to the polyethylene powder before irradiation, and by doping, when the polyethylene is actually soaked in a solution of vitamin E. Now, if we compare the wear rates, I have compared it as in vivo, in vitro, and in animal models. In animal models, vitamin E implanted into rats after 6 months, it confirms having ability to prevent oxidative degradation. This now flowchart or this diagram now depicts two things. One is the blended form of vitamin E by depicting, which is depicted in the yellow arrow, and the red one in which the doping form is done. So what we can see here is that in the yellow arrows, the blended form, there is high oxidative index. That means to say that there is increased wear with increased duration of the polyethylene, as opposed to doping in which the wear or the oxidative index is very low, negligible, as and how the months are passed. Thus, in this slide, we can know that doping is always better than blending. So doping trumps blending, as we can see. Now, another flowchart here gives us an idea about the wear rates of vitamin E poly as opposed to conventional poly. The wear rates are very low is compared to a conventional poly, as in how the number of cycles are being repeated. Another flowchart, another bar diagram giving a less wear rate, conventional versus vitamin E poly. A surface oxidation reduction index is much lower for a vitamin E irradiated polyethylene. Many studies have been compared. All of them give an idea that standard polyethylene has a higher wear rate as compared to vitamin E, as we can see in this image. Now, mechanical properties. Does it have an impact on mechanical properties? Per se, vitamin E added polyethylene does not change the mechanical properties. There are many studies to show that incorporation of vitamin E didn't change the mechanical properties. Conventional polyethylene failed after 31,000 cycles and vitamin E doped failed after 53,000 cycles. So much to say that there is not much change. There is a trade-off between the cross-linking and mechanical strength. The more cross-linking happens, as we can see in this diagram, there is increased wear resistance, but the mechanical properties, so to say, reduce. There was no change seen in the fatigue failure rates, which is important for total knee arthroplasty. Now, how much of vitamin E is enough? Do we have an answer? Yes. For doped vitamin E, as low as 0.01% per weight is adequate, but for blended vitamin E, even 0.02% weight are not enough. As we can see in the yellow diagram, yellow bar, at 36 months, it shows a wear of about 0.16. Now, vitamin E as an antimicrobial, there are many papers to say that it reduces microbial adhesions on ultra-high molecular weight polyethylene. So, does it actually prevent biofilm formation? The answer is a big no. No, it does not cause so. Other properties, so to say, of vitamin E are there is reduced production of inflammatory cytokines. So, the foreign body reaction of polyethylene in the body is less. In short-term measures in vivo outcome, the articles which I could find, they gave no change in both polyethylene of vitamin E soak as opposed to conventional polyethylene. Both the outcome measures were equal for short-term duration up to 5 years. However, there are still no long-term results or long-term studies for polyethylene with vitamin E compared them with conventional for total knee arthroplasty. Recently, there is a study in Journal of Arthroplasty in September giving 10-year follow-up of vitamin E in THR. And for them, there is promising data, so to say, that the wear rates are 10 times lower. As we can see, the wear rates are 10 times lower in a vitamin E soaked liner as opposed to conventional liner. Therefore, there is hope we have a winner in the future. The take-home message from this presentation is that there are better outcomes of reduced wear rates. There is not much loss in the mechanical properties. Doping versus blending, doping wins the race. It has antimicrobial properties, reduced inflammatory response and foreign body reactions. The short-term follow-up in vivo results are equivocal for vitamin E and conventional, but the long-term are yet to be assessed. They're giving good results in THR. These are my references. Thank you for your patient listening. Thank you so much.
Thank you, Dr. Soham. I'll invite the judges for questions.
Dr. Soham, the mechanism of wear the TKR is different from that in total hip replacement. It is a subsurface wear. So, do
Yes,
we
sir.
have any simulator studies in vitamin E doped or blended poly in TKR?
Sir, the wear in TKR is basically a fatigue wear as opposed to an abrasive and an adhesive wear in total hip arthroplasty. The mechanical properties, so to say, in vitamin E doped poly, there are results and there are studies which say that there is not much change in the mechanical properties. So the incidence of fatigue failures or fatigue strength reduction is also negligible. It is not significant in vitamin E doped poly as compared to conventional polys.
Yeah. Are there any simulator in vitro simulator studies
Sir,
in vitamin E totally replaced?
Sir, can I have your question again, sir?
Are there any in vitro simulator studies of vitamin E used poly in total knee replacement?
Yes, sir. There are in vitro studies which show that there is reduced fatigue, delamination studies. There are delamination reduction studies which are seen. And even though they give that there can be a chance of slight increase in delamination failures, it is not significant per se. And the benefits or advantages of vitamin E doped poly are much more as opposed to that of conventional poly.
Thank you.
So, just one question. You mentioned about the wear which happens in two situations, the total lip and the TKR. Now, there are a lot of papers where they have shown that the in vivo and the in vitro particles are not different when you add the vitamin E. There are a lot of papers which are supporting that. So, does that affect the wear rate if the in vitro particles are exactly the same as compared to in vivo?
Sir, even though the particles are the same, the reaction which the body has to these particles is less in vitamin E poly. There is anti-inflammatory production, or the cytokine production is less, as I have mentioned in one of the slides. So the reaction which the body gives in vivo, there is reduced chances of a tissue reaction happening to the debris in vitamin E poly as compared to a conventional poly.
So, Soham, is it safe to say that we should have vitamin E added to all polyethylenes? Because at the end of the day, it has no negative effect. It may have a beneficial effect. Is that fair to say as per your reading?
Yes, sir. It is fair to say the only reason in total knee arthroplasty, if we increase the vitamin E instillation or the doping, it leads to slight reduction in the mechanical properties. There is a threshold of 0.8 percentage weight. If you cross that, usually it is not crossed in all the studies. It is monitored and it is kept in check. But if the mechanical strength is reduced by addition of vitamin E, it would not be desirable in a total knee arthroplasty as opposed to a hip arthroplasty. So that is the only drawback of vitamin E liners for TKR as opposed to that in THR.
So the jury is still out. Okay.
Sir?
So we are still waiting for better studies to know
Yes, sir.
whether
We are
vitamin
waiting
E
for
can be-
long-term follow-up. There are no studies. I have actually tried to find out long-term studies, but the maximum I could get was up to 5 years for total knee arthroplasty. There are studies for total hip, but for total knee arthroplasties, there are no studies more than 5 years. And that is why the data is still insufficient for long-term follow-up and survivability.
So again, playing the devil's advocate, no effect of alignment on your polyfair, no? Vitamin E or
No,
no?
sir.
No. Okay,
Sir,
thank you very
that
much.
would be
Lovely
same.
presentation.
That would be same for even in a mal-aligned poly, or there would be no difference between a conventional poly versus a vitamin E poly.
Yeah.
There will be
Noted.
the surgeon has a Midas touch.
Right. So any other questions, Ashish, Darsa?
No, I think so. Good presentation overall. I think I must have missed that point. You said that doped poly requires less vitamin E and blended requires more vitamin E to achieve the same effect or the same wear resistance.
sir.
Is that correct? Then,
Yes, sir. Yes, sir.
I mean, are we still having commercially available polys which are blended, or they are now all doped?
So most of the polys are going towards dope. The mechanism, the difference is that in blended vitamin E, the actual addition of vitamin E is before the irradiation. So what they
Yes.
do is they add vitamin E to the poly powder, to the monomer powder,
No, I got
and
the
the
difference.
entire composition.
Yeah. Yeah, so I got the difference.
Yeah.
So if you are saying that if there is a effect of oxidation only on the superficial or it's a delamination, then doped one makes sense because you are just tackling those. And if blended, you don't need as much of vitamin E. Is that correct? Because the wear characteristics are, the oxidation is not going to happen in the deeper layers of the poly.
Yes, sir. Sir, the delamination, actually, the most common failure for the TKR is basically the fatigue strength, the reduction in fatigue strength. So that is why the vitamin E poly in TKR are having that issue, for which we need to counter the actual percentage of vitamin E and monitor the strength. The doping versus the blended polys, the actual percentage of vitamin E elution which is happening inside the poly after blending, it is found in many studies that the vitamin E just disappears, or it is quenched up, or it is exhausted before actually it comes in contact with the body fluids. So as a result of that, once the process is finalized and done, the surface addition of doping would have a beneficial effect.
Okay.
So doping trumps.
Yes, sir.
Yeah.
Blending is democratic. So we'll go doping. Well done, Soham.
Okay, great. Any other questions? Okay, let's move on to our next presenter, Dr. Aashay. Aashay, please share your presentation. He'll be presenting on patellar resurfacing versus non-resurfacing, kind of eternal debate in arthroplasty.
Soham is a Ranade, na?
Yeah.
South Indian accent है उसका एकदम. Bombay का ही है ना?
Can you see my presentation?
Sir, me
Yeah,
Raigad Mahadsa hai, sir.
अच्छा, good.
Yes,
Maharashtra.
Maharashtra. Jai Maharashtra.
Ashish, you are in election mode.
No. I just thought that he had a very strong South Indian accent. I was wondering whether he's trained in the South and while he was presenting.
Right.
We were marking them on presentation.
He's got a mass appeal, which is the need of the hour.
Yeah.
Aashay, what happened to your presentation? Yeah, go ahead. We can see your presentation.
So can you see my presentation?
No, are you presenting it from a phone?
Yeah. Hello, good evening to everyone. My name is
We are not able to present.
I think he's presenting it from a phone.
Chennai as a fellow in Arthroplasty and Arthroscopy. So I'm using my iPad, sir.
Okay.
Okay, go ahead.
Should I get on this? Is this better?
No.
No, the earlier one was better.
Yeah. Go on.
Okay. So I'll start. Good evening, everyone. So my topic today is patellar resurfacing versus non-resurfacing in total knee arthroplasty, a review of pain and function. So the earlier total knee arthroplasty design were associated with a very high level of anterior knee pain, and that was often attributed to the patella being non-resurfaced. So in the 1970s, patellar resurfacing was introduced, and since then there has been a drastic improvement in the designs of patellar component and the patellar button. So historically, the patellar button, when they were introduced, they were cementless and they were metal backed, which had a very high rate of complications, which included loosening and fractures, polyethylene wear, extensor tendon ruptures, and earlier they also had a routine practice of lateral retinacular release, which was questionably related to avascular necrosis of the patella. So the methodology which I have followed is I have searched for all the randomized controlled trials in the last 10 years, and my mesh terms were patellar resurfacing, patellar non-resurfacing, functional outcome, and anterior knee pain. So on the basis of my research, I found 39 results on PubMed, and out of which I could find 6 randomized controlled trials that I was looking for, which compared directly the resurfacing and non-resurfacing of patella. 5 of them were in English and 1 was Chinese language, which had an English translation. And the 2 terms which I was looking for is pain, which was basically anterior knee pain, which for which the surrogate markers which I was looking for was pain while getting up from a sitting position from a chair and pain while climbing up the stairs. And the functional knee assessment was done using the Knee Society score. So now that we have patellar resurfacing, it is still heterogeneous in the orthopedic community as it is very surgeon dependent. It depends on where the surgeon has trained, depend on from the data from the different registries around the world, which show that in North America, 90% of the surgeons prefer resurfacing their patella. And in Australia, we see an increasing trend from 41 to 60%. And the National Joint Registry in UK shows that about 1/3, that's 33% of the surgeons prefer resurfacing the patella. The Scandinavian registry, on the other hand, is called BOS, where Sweden and Norway
show only 2% in the knee. So what do the proponents of resurfacing say? That they have a better knee function, which is questionable since the articles which I searched for the last 10 years show that the patients who resurfaced and non-resurfaced had a similar patient-related outcome in the post-operative period. The surgeon definitely has some better post-operative satisfaction as he is potentially buying only one surgery for the patient, which is a resurfacing has a lower reoperation rate as compared to non-resurfacing. As you can see in multiple studies that have been posted here, the resurfacing is definitely a cost-effective one when we see it in a long term and has a lower revision rates. And definitely resurfacing is associated with anterior knee pain as it takes care of the worn out cartilage, which is a pain generator. Coming to anterior knee pain, it should not only be attributed to whether the patella was resurfaced or not. It is often due to other causes which range from discomfort, numbness, bursitis, accurate balancing, or traumas in knee. That a series of patella for success rate. Only 44% have knee pain after second. And given data 20. So resurfacing is of course not elevate risks. We can see avascular necrosis, aseptic loosening, overstuffing the compartment, patellar syndrome, which lead to the other, which is the patellar pocket. They are the surgery is associated with more fractures. You are expecting the need to an additional trauma. There is no suggestion, evidence from the that we have from the randomized assessment. So the 6 random controlled that are 5 out of that the knee society score, the functional component of the knee score, difference in the resurfaced and non-resurfaced groups, whereas only one is from by Ziha, which have done 6 knees in which one of the knee was randomized to the other one was non-resurfaced and have a 5-year follow-up. Show that this is a difference in resurfaced and non-resurfaced group in the knee society score. Also, the post-operative satisfaction of the patients was better in the resurfaced group. That's 47% resurfaced or not. So we see that the patellar resurfacing is now slowly going out of favor. Why is that? Because of it's in the processes design, the patella-friendly humeral components which are being introduced, which have a deeper trochlear groove, accommodates better surgical techniques, where the alignment philosophies are now towards kinematic alignment, which ensures and preserves the soft tissue envelope around the knee and resurface only the worn out parts. Which brings us to the third group, who are selective resurfaces and claim that there is a decreased incidence of anterior knee pain and certainly gaining popularity as evidenced by the National Registry in 39%, and Australia and New Zealand almost 66%. That is 2/3 of the surgery are selective resurfaces. So what do you mean by selective? What are the indications? So they do resurfacing in inflammatory conditions where the intraoperative finding of patellar subluxation, mal tracking. In a paper this year in Journal of Arthroplasty by Daniel Reddy, who reviewed about 50 cases in the and all of the patellas were selectively resurfaced. They say that the patients who have moderate severe pain have a greater likelihood of post-operative knee, and there is no association between all patellar reading and by which is a controlled trial for selectively difference in the knee score or survivorship of it. And he says majority of the patient remaining patellar irrespective of resource. So other thing method is artery circumferential elevation of the patella has shown to be recently using the BAS score for anterior knee pain and improves the clinical outcome in terms of the patient-related outcome measures. There's another paper, Ryan Spencer in Orthopedics in the year 2016, who shows that patellar resurfacing versus circumferential denervation actually have similar incidence of anterior knee pain. And the other method of patellar resurfacing that surgeons nowadays are preferring are patelloplasty, which is basically resurfacing of the patella so that you recreate the articular surface of the patella which matches the trochlear. And it is a safe, easy, and a very effective method. And it has shown in various papers to have a better knee society score, Oxford knee score, and a better quality of life. So, in conclusion, I would like to say that patellofemoral contact is the thing that we should be looking out during the entire range of motion, which is essential to reduce the anterior knee pain. Patellar resurfacing is definitely cost effective in the long run as it has lower revision rates. But having said that, identifying worn out, unstable, mild-tracking patella intraoperatively in appropriate patient population is the way to go. Thank you.
Thank you, Dr. Aashay. And like we made a point in the beginning itself, not to use iPads or phones for presentation. Many of the judges, Dr. Avinash couldn't see the slides and your voice was breaking. So the rest of the Rising Star contestants, please keep in mind always present with a laptop and a good internet connection. Go ahead, judges, for your questions.
Just Dr. Akshay, you made that point. You showed that one of the slides showed a CAP classification and a patellar resurfacing. It was quite interesting.
Yes, sir.
Now, perhaps I could not hear you well, but what did you want to did you want to denote say something about that patellar resurfacing and the alignment? This thing, does it have any correlation? Did you want to say something about that?
So patellar resurfacing definitely is in the alignment is the main component that we should be looking for instead of deciding whether or not we should be resurfacing the patella. Because until and unless the alignment and the component positioning and the soft tissue balance is right, anterior knee pain would still persist irrespective of whether we resurface the patella.
I would like to interrupt you, Dr. Akshay. The alignment of these classification are coronal plane alignments. They are not rotational alignments that we are describing. But it is quite interesting that this may have some impact on the patellar resurfacing. So can you elaborate? I mean, the classical mechanical way and say I would take a kinematic way. Would patellar resurfacing would it matter as regards the alignment philosophy and the patellar resurfacing? That is what I wanted to ask.
The patellar resurfacing would always be a step down. The kinematic, the alignment, whether you're doing mechanical, whether you're doing kinematic, that is the most important thing. The rotational alignment, the rotational position of the components is to be taken care of before we think of resurfacing or not. If at all we see that after doing any of the alignment that the patella is not tracking well, the patella is having a lateral subfixity, then is the time that we need to resurface the patella.
Akshay, I hope you're not sitting in the pub in the picture in the photograph, but would like to.
Diwali decoration.
So what I wanted to check with you, you mentioned about resurfacers, non-resurfacers. What are your views and your literature? What does it say about selective patellar resurfacers? Any role?
Yes, sir. Selective patellar resurfacing have a better outcome in terms of patient-related outcome measures and cost effectiveness, as you look individually at each of the patients as to which patella is the one which would not be behaving in a way that we'd want it to inside the joint after we have replaced the arthritic components of the femur and the knee. And only those patellas are the ones which we need to touch. And the other patellas, we can go for patelloplasty, which is quite an effective and a popular method of taking care of the patella.
Dr. Aashay,
yes, sir.
Any thoughts on femoral implant designs? Because some femoral implants are what we call, into inverted commas, patella friendly, and
yes,
some
yes.
femoral implants are not patella friendly.
Correct.
So, my humble opinion, implants that are not patella friendly should have the patella resurfaced in each and every case.
Yes, sir. You are absolutely right.
Your views on that, please.
Sir, the newer implants which are coming in now, the femoral components especially, has a deeper trochlear groove which articulates well with the patella during the entire range of motion of the knee. That is from 0 degree of extension to about 90 to 100 degree of flexion. And the patella, the pressures which are at the patella femoral joint during these amounts of flexion are the ones which need to be taken care of while aligning the knee. So the newer designs which are coming in are more patella friendly as compared to the previous ones. So in newer designs, it is not always necessary to resurface the patella.
So you mean to say a knee designed by Sharma Surgicals will be as patella friendly as the persona designed by Zimmer?
Sir, it's an intraoperative finding that we need to see whether the patella is tracking well, whether there is any subluxation. And
no. We are assuming it's the same surgeon, same alignment principles used, same soft tissue dissection, everything. I'm not talking about the femoral implant geometry. Is there anything to suggest that certain femoral implants are more patella friendly, and in other scenarios, it is better to do it rather than not do it, because a resurfaced patella tolerates subtle malalignment better than a non-resurfaced patella. Am I right?
Right, sir.
Thank you.
Absolutely.
Okay. Thank you, Dr. Aashay. Any other questions from Dar sir or Ashish sir?
No, I'm good. Ashok, unfortunately, I missed a part of the presentation. So,
Yeah.
Good, Ashay.
Okay. Let's invite our last presenter for today, Dr. Avinash. Go ahead and share your presentation, Dr. Avinash. Okay, we can see your presentation.
Am I audible, sir?
Yeah, you're audible. Start the slideshow and go ahead.
Good evening, everyone. I am Dr. Avinash Upadhyay. Today, my topic is single radius versus multi-radius knee implants, their functional and biomechanical outcomes. So as we know, total knee arthroplasty has been effective surgery to relieve pain and restore the patient's mobility with advanced knee osteoarthritis and rheumatoid arthritis. Despite total knee arthroplasty's success, 20% patients are dissatisfied with this procedure post-operatively. The challenges, this could be attributed to many factors, including decreased range of motion, mid-flexion instability, unable to replicate the natural knee kinematics. So over a long period of time, the total knee arthroplasty using multi-radius prosthesis was considered a good choice to treat osteoarthritis. But in recent years, due to post-operative complication like instability during mid-flexion and weak quadriceps post-operatively, we have seen the patients were dissatisfied after the multi-radius total knee arthroplasty. So total knee arthroplasty using single radius prosthesis possesses a single femoral component which was introduced for overcoming this drawback. The single radius design theoretically could avoid inconsistent movement of femoral component and extend the moment arm of extensor mechanism when the knee was moderately flexed. Objective of my review of literature is primary are the comparing the functional and biomechanical outcomes of single radius versus multi-radius knee implants. And other I would like to include in assessment of patient satisfaction, post-operative stability, and complication rate between single radius and multi-radius implants. So I check all electronic literatures, PubMed, Web of Science, and the keywords I included were single radius, multi-radius total knee arthroplasty, and meta-analysis randomized control trials. So I searched for all the literature, and after reviewing the literature, 219 records were found, and of which only 12 were eligible studies which I took for reviewing. So where do you stand today for single radius implant versus multi-radius implant? So as per the review of literature, as you can see in the graph, post-operative knee range of motion, there is no significant difference between single radius versus multi-radius implant. And as per the pain score level, there is similar pain levels reported from single radius versus multi-radius group. If we compare satisfaction, the single radius group shows higher satisfaction level, and sit to stand test, it has higher success rate in single radius implant group. There was no significant difference in American Knee Society score between single radius and multi-radius, and similar was the Oxford Knee score. There was no significant difference was found. The quality of life outcome, including mental and physical well-being, both group have similar outcomes. Now I will come to biomechanical outcomes, which will include anteroposterior stability. Single radius design may help stabilize the knee in the anteroposterior direction by maintaining a uniform radius, potentially allowing for more predictable control in the knee joint. However, both single radius and multi-radius design allowed slightly more anterior laxity near full extension compared to the natural knees, because there was lack of anterior cruciate ligaments. Another component is rotation in varus valgus laxity. Both single radius and multi-radius implant provided similar varus valgus stability as compared to the natural knee joint. There was no significant difference in this component. As far as the complication rate was concerned, there was no significant difference between the two implant designs. So I would like to conclude by saying there is no significant difference were observed between single radius and multi-radius in key functional metrics like range of motion, knee scores, pain and satisfaction scores. Both designs are effective in total knee arthroplasty with similar patient-reported outcome and complication rate. Although single radius implant may be slightly improve the patient satisfaction and the quadriceps function post-operatively. In terms of biomechanical observation, single radius implant provide more consistent ligament tension across the flexion, and potentially it reduces the mid-range instability. Multi-radius designs, while theoretically susceptible to ligament laxity in mid-flexion, demonstrated comparable stability to single radius. So stability and functional outcomes in total knee arthroplasty are inconsistent in surgical technique than by implant geometry alone. Single radius and multi-radius implant both provide reliable function and biomechanical outcomes. But we need longer follow-up studies and evaluation under dynamic or high load condition where we could compare this single radius versus multi-radius designs. These are my references. Thank you.
Thank you, Avinash. And paper is open for questions.
Dr. Avinash,
Yes, sir.
the single radius also, there are few single radius in both coronal as well as in sagittal plane, and few are single radius only in sagittal plane but not in the coronal.
Yes, sir.
Yeah. So did you find any difference in the literature between these? Because so-called single radius also there are varieties. So did you find any difference between these two designs?
No, sir. I could
So
not
it
find
was perhaps not in the purview of
studies
your
which were
talk.
Yes, sir.
Though it was not in the purview of your talk, during the search, did you find something?
No, sir. I could not find much literature comparing the single radius in coronal and sagittal plane. Only I read the articles who were comparing single radius versus multi-radius design.
Dr. Avinash, did you notice any papers where there is any difference in the outcomes between cruciate substituting versus retaining knees, single versus multiple? Did you come up with anything? I mean, is this configuration better for a cruciate retaining person? This is what I'm trying to.
In a few papers, I
Yeah.
had noticed that single radius implants were used particularly with cruciate retaining design like philosophies, cruciate retaining philosophies, and multi-radius where multi-radius implant design was used with cruciate substituting philosophy.
Any other questions?
Avinash, any idea, any views on the medial pivot knee since you are at it?
Medial pivot knee is being used since last few years, but there is no sufficient data that could. I wanted to add this in my study comparing a single radius, multi-radius, and medial pivot, but I did not find much data for the comparison, sir.
Thank you.
Thank you, sir.
Okay. So I think that was our last presentation today. So thank you, everyone. Thanks all participants. I think all presentations were really, really good. Darsa, you want to say some?
No, let Dr. Desai wind it up.
Yeah. Go ahead, sir. Desai, sir.
No, nothing. I mean, I don't know. I have been the judge for the first time for this sort of a thing. I don't know how many do we select out of these.
So
So
we'll
we
have,
have to give marks, top ranker, and then finally we decide. We have to rank them. The judges
Okay.
have to rank them. I don't know whether you are a judge or you're just there as a president.
And then I'm
Ashok.
just here.
Okay.
Okay.
So the judges will mark them and then they will submit it to Ashok. Finally, after all the sessions, we'll choose. I think we'll decide about how many, whether 5 or the last session will be, and then the finalist will go to the YROC.
Last year I wasn't there. I mean, this time I'm
Yeah.
there. I joined as the first time, so it was a nice experience. And, everyone had done a good job. They had done a good literature search and given justice to the presentation.
Yeah, they are all excellent
It was
presentations.
a learning experience for me as well. I learned a lot listening to this presentation. It was a sort of a consolidated, a sort of a literature review sort of a thing, and it was really nice.
right. So judges, any points from you?
No, I think excellent presentations overall. Only that that Ashay's presentation seemed good, but were not coming across as best as much as it would have been nice to hear. So unfortunately, that is a little blip. But otherwise, the content-wise, no complaints. All very well presented, researched, and they answered whatever they could from their presentation. But there are things, of course, which are still out in the open. So we just have to wait for long-term data. But overall, excellent work by all the 5 participants.
Yeah, excellent tools were used for analyzing the literature, which during our times was quite limited, but now it's quite extensive research of them.
Right.
Yeah, in fact, this is a revelation for us seniors also. How to improve our own presentations.
Right.
Good learning.
Yeah, Ashish.
Ashish might wind up.
Sorry, I got logged out. But I think it was a very, very good presentation by all 5 of them, and very well researched, well presented. The standard of presentation, I think, has gone much higher. And as Sir said initially, it was to encourage the youngsters and also for us to find out who the next generation of speakers, the faculty is going to be. So we could slowly, so cultivate and inculcate this but interest in among juniors to participate in the BOS courses and the BOS academic meetings that is there. So thank you very much to Dr. Girish Devani and Avinash, dear friend. Thank you very much, sir. Ashok and Neeraj, thank you very much for Ortho TV and for hosting us and partnering with the BOS. And finally, to all the 5 participants, all of you have done very, very well. Let's wait to hear what the judges have to say. And this, of course, will be available to all of us on the YouTube channel. So feel free to sort of,
Share it with
media, because the content that you have presented is very, very good. I mean, anyone can write a sort of a short note, a long answer for their exams, or people can use it as a reference as well. Thank you.
Absolutely. So
Thank
thank
you.
everybody again, and we are winding up this first session of round 1 of BOS Rising Star. Thanks a lot.
Thank you. Good night.
Thank you.
Thank you.
Bye.